Hello, everyone. My name is Teresa Chan, and I am here to be kind of your host, kind of another speaker for today's event. I am going to welcome two of my co-speakers right now, panelists, I guess, Dr. Daniel Brent Vegas. So wave hi to everyone, Daniel.
Hey.
And Dr. Chad Singh. Wave hi to everyone, Chad.
Hey, everyone.
All right. So I'm excited to have you both here because we're going to be talking a little bit about CBME and what it means for all of us in terms of programmatic assessment. So we did send around the pre-reading. Then hopefully, if you had a chance to read it, it's an article about 12 tips for programmatic assessment, and it will be helpful. And then we're gonna kind of dive into kind of talking about the concept of programmatic assessment. I'm gonna kick it over to Daniel first. If you could chat with me about what is programmatic assessment.
Yeah, thanks. Hi, everybody. Thanks for joining us. So I think the first thing that I will kind of start with for you guys to hopefully contextualize things, bring assessment in the broader curriculum sense, and thinking of assessment as really the way that we measure whether or not the learners in our program are acquiring the skills or the knowledge or the competencies that we are hoping that they're going to acquire during their training. And are they progressing? How are they progressing? And are they ready to graduate at some point? So I would kind of hope that we start with contextualizing assessment in that way. So we kind of have that broader, more fundamental conceptual thought of assessment. I think, you know, the second part, maybe just to add to that, is the idea that, you know, this is why I'm linking it to curriculum. It would kind of link to something like the Bloom's taxonomy, where we're going to be assessing different things, and therefore, you know, we're measuring different things in different settings. And so, you know, we want to probably use different assessment or measurement tools to measure these different things in different settings. And so this is maybe the first step in thinking of programmatic assessment, or a program of assessment, is to think, what are the things we're measuring? Where are we measuring them? And what would be the best way to measure that specific thing in that specific setting? And that's a good, I think, primer to get started.
And so when you're talking about Bloom's taxonomy, that's the idea of like just, you know, rote memory, like that's like the basic, and then you want to like think about understanding, which is a little bit for deeper. You want to think about application, which is probably when you're hitting like the words and trying to apply some of your knowledge or skills. Analyzing would be trying to figure out maybe clinical decision making as to when to actually apply, you know, a certain diagnostic heuristic or diagnostic algorithm or a management plan. Evaluation is when you actually judge the information for ideas, and then the top of the pinnacle is really about creation, right? So probably in medical,
I mean,
we don't do a lot of the creation part.
No, but I mean, I think it's important for us to start thinking of, again, the right tool for the right type of measurement. So if we want to know if someone knows something, the best way and the easiest way is probably just having some kind of written form test, or maybe a brief conversation about that knowledge. But if we want to actually know whether someone is able to carry out something, whether it's an acute resuscitation in a patient in shock, or whether it's doing a lumbar puncture or intubating a patient, you know, asking them to write that down is probably not the best way to know if they can do it, but rather having some kind of way of seeing them demonstrate it. And so in that range of different types of skills and knowledge and understanding, and then demonstrating, we're going to sort of strategically pick different measurement tools.
Okay, that makes sense. So what you're saying is that you almost need like a strategic plan for how you're going to measure and assess whether or not a trainee is ready, but you're going to do that in a programmatic way. You're going to assemble it not just as one final high stakes exam at the end of residency, maybe two. It is Royal College Week for our emergency medicine trainees, so it's on my mind. But that's the way that I came through, right? Single high stakes exam. There were formative testing along the way. There was other stuff, but it really didn't matter except for that one exam. What you're saying is that maybe we should expand beyond that, and think about other measurements and other tools for other circumstances. So the knowledge tests of knowledge may help with the knowledge acquisition and confirming
Yep.
that I know what I need to know, but they probably don't test my communication skills very well, or conflict resolution skills, or something that's a little bit more higher order where you actually have to put things together, right? They're definitely not going to tell you if I can flow the department.
And I'm a big metaphor type person, so
Yeah.
I'll offer you guys a metaphor to transition to the next point. But if you were going somewhere, you were traveling, from point A to point B, you wouldn't want to know whether you got to the right place at the end of your journey by looking around and saying, am I in the right place? You'd probably want a GPS. You'd probably want constant, frequent input and feedback and measurement of where you are and where you're moving. And do you need to reposition yourself, or do you need to reorient yourself, or are you moving the right direction? And so programmatic assessment is a similar idea, where it's having sort of structured, well-planned and frequent measurement that will tell you where your trainees are, if not in real time, but close enough that you could help them reorient or reposition themselves as needed.
Okay, all right. Now that totally makes sense to me. Why don't we kick it over to Chad now? Chad, I'm going to put you on the spot as a trainee who's in a CBME CVD program. You're in the lead year of the cohort that we started in 2018 for emergency medicine. Can you speak to me a little bit about your perspective on programmatic assessment as a trainee? How has it been helpful? How is it, what are some ins and outs of it?
Yeah, absolutely. And I think for us, when we were coming into our emerge first year, my colleagues and I were all like kind of looking around each other, like, what is an EPA? What is CBME? And there was all this hoopla about it as we were coming in. And you quickly realize that why haven't we be doing this the entire time? Because it makes so much sense when you're on shift or you're off service. You have, like Dr. Braviggs was saying, these frequent assessments that you're able to do in various different contexts, whether you're on the ward, off service, whether you're intubating somebody in the OR under anesthesia, or whether you're actually in the emerge. You have all of these different frequent milestones that you're achieving, and there are different ways that you're being assessed, as opposed to, like you were saying before, Teresa, that final end-all exam. And I think for me, that's allowed me personally to really look at what it is that I want to get out of that shift that day. What is it that I want to get out of that block, for instance? So an example might be in PGY2, the entire block, I really want to focus on any presentations that of an obstetric presentation. And I really want to focus on that. And those are the EPAs that I want to tackle that month. And it gives me a little bit of context to talk to my preceptor and address my learning goals as a personal learner. And really work through some of those assessment milestones, working towards becoming very proficient in those presentations. So it's really allowed me to really almost tailor my learning more appropriately to what I want to get out of the residency program. On top of that, giving us those checkpoints along the way to say, hey, you actually are progressing at a very decent pace. You're able to actually reach that final end all exam at the end of it, but you've been adequately assessed in all the other domains that make you a proficient doctor.
Okay, and so it was kind of a new thing for you to have kind of these workplace-based assessments. You've done some MAC dots and things like that, so you weren't completely foreign to the idea of direct migration. Any pro tips in being able to get the buy-in, from day to day for engaging in that programmatic assessment?
Yeah, absolutely. And I think it's just as much on the learner as it is on our faculty to, as you said, buy into the whole process. From the learner perspective, I think when you start to look at these assessments as almost a learning tool, and how to help you as the learner become a better physician and really progress through residency, you can look at your EPAs and almost say, what is it that I want to get out of that day? Before you go on to shift, or before you go on to the ward, for instance, and really try and say, what is it that I want to be assessed on? How is it that I want to grow today or that block as a physician, and then use that to approach your faculty or to approach your preceptor and come up with that learning plan, and almost use these EPAs or these learning assessments as little checkpoints along the way, so that you can actually show yourself having growth throughout the progress of that block. I think from the faculty perspective, it's funny because when we started off, I think the year above us was the real guinea pig year. They were the ones that actually started the process with going through the different EPAs with the faculty in the emergency department. By the time we got there, things were pretty much smooth sailing, and all it took was how to actually fill out the form here and there. But faculty generally wanted to give that feedback, and when you were able to direct them about something specific that you wanted feedback on, I personally found that the feedback was much more positive received on my end.
Okay. And tell me one more thing. In the Emerge program, you don't only get EPAs, like there's other forms of assessment that are in the program of assessment. Is that correct? Can you talk to me about some of the other things that you are assessed on?
Yeah, absolutely. So in our program, I mean, EPAs are just, like you said, one realm of it. We have our whole simulation curriculum where there are assessments through there. There's our academic half day or academic curriculum where we have our block exams that are kind of these frequent checkpoints along the way throughout the academic half day curriculum, where we have some formative testing on the content. And then twice a year, we have a national exam. So I don't know if anyone else went to Mac for med school, but it's similar to the exams that we wrote 3 times a year that shows your progress throughout the entire curriculum. And that's what these national site exams are called.
I have a question for you, Chad. What would you say are some challenges from your point of view as a learner? And it's hard because maybe you started your residency during sort of knowing or with the experience of some programmatic assessment. But when you hear about what we are referring to is the programmatic component of the assessment in your program, what do you think are some challenges from your point of view as a trainee?
Yeah, I mean, I think it's hard to answer that question because it's the only thing that I know. And I think, having leaders such as Teresa, who's done such a great job in really training our faculty on what this is the new way of how how our learners are being assessed. It's difficult to put one thing that's a challenge. I'd say off service was probably an area where our residents in particular found a little bit of difficulty. In the Emerge, it's very regimented in that you are with one faculty, you are, you work them the entire shift. You may intubate somebody, and then that's a learning opportunity where you can get an EPA for that. And then you may have, saw a critically ill patient, and there's a learning opportunity for that. And you're with your faculty, so you're able to approach them in that moment. It's almost like just-in-time assessments. Whereas opposed to when you're on the ward or you're on a surgical rotation, for instance, it can be difficult to almost sometimes engage that faculty and, hey, I just did this primary survey for a trauma patient. Can I get an assessment, or can you watch me do that? I think that was probably the difficulty up front. I know our learners this year coming around have had a lot more success. And again, that's just through the various faculty development on the different areas, because I think a lot more programs are doing CBME this time around. Things are starting to come a little bit easier for our learners when they go off service.
So there's a couple of questions in the chat there that I'll kind of work into the conversation because it builds on what you're talking about. And maybe I'll start backwards just to, Eva Peasons, Dr. Peasons from ID, who's joined us, hi Eva, is asking, and this is an important, somewhat contentious, but really important point about how do you as a learner know what you need to know? Is there a risk that you might lose the forest for the trees if you're kind of looking for whether it's the EPAs you need or the one thing that you're particularly interested in or that you've identified as a need? How do you keep from not having things that you haven't identified or that are not in the EPAs that you might miss? And I'll let you answer that for a second, but maybe I'll just kind of contextualize that. that's exactly why programmatic assessment is so important, because it's not exclusively by any means a singularly learner led and kind of defined assessment strategy, but rather a program mapped out and carefully planned out strategy. But especially with CBME and EPAs, it's allowed for learners to kind of guide it within kind of a design that already exists and that the program has carefully placed, but it gives the learner kind of the opportunity to proactively seek out and prioritize things, but not only focusing on what the learner wants. But what's your perspective in that regard?
Yeah, and like you said, it's not just the EPAs. It's not just like, let's get all of our check boxes filled out and then we're magically, ready to be an attending. I think it's like you said, it's a very holistic way of training a learner. So there are the EPAs where I personally use them to identify my learning gaps or something that I might not have seen on shift before, or there's something that, I'm not really getting the 4s and the 5s. I'm not getting the feedback that I wanted. How can I incorporate all of those tips and feedback that I've gotten in a specific area? For instance, managing an airway. So I had 2 airways these past few days, and I've been able to take the feedback that I've gotten, say, from a month ago on the last couple of EPAs, and really try and change my strategy in tackling a difficult airway. So it's using the EPAs to identify things that you might want a little bit more practice in, or it might also be using the EPAs to say, hey, I have never seen this before. This is something that I want to go out and seek out while I'm in the department, just trying to learn. But it's so much more than that. We have our block exams, we have our site exams, we have our meetings with our assistant program director and program director at regular intervals to discuss how you're progressing throughout the program. So I wouldn't say it's just the EPAs that are what we're being tested on. It's more of a holistic program, like you mentioned.
And I wonder if, from my conversations and observations from an internal medicine point of view, to Eva's point, I think what you're describing, and having worked with you, I know that you're a very reflexive, intrinsically motivated, and mature learner in that way. And so one of the challenges might be that it requires a certain type of learner, or it will favor a certain type of learner, and other types of learners might struggle if they're being too opportunistic, or if they're being if they're uncertain of where to go next, and if they feel a little less motivated or are looking for more external guidance. Spencer asked, so he brought up a survey from Quebec that, and I would strongly echo this. I've heard a lot about this from internal medicine residents, that residents or learners, they find that there's a whole layer of bureaucracy. And this is maybe CBME focused mainly, but I guess when you do more assessment, whatever that assessment is, and programmatic assessment for sure, has a lot of assessment. If you're going to strategically and frequently assess, then that means more measurement events. There's a whole layer of bureaucracy, whether it's filling out forms, whether it's having encounters that are no longer just organically happening, but now there's a score and a form and a process attached to it. And learners have felt like it's a whole new layer of work that they have to navigate, and their progression and promotion depends on it. Do you have anything to say about that?
Yeah, I totally agree with you in some aspects of, at the back of your mind, there is always that I want to be progressing at a rate that is equivalent to my peers, and I want to be hitting those almost like the check boxes to move on to the next stage. I think using technology has been able to help us, almost decrease the bureaucratic nightmare that, not having a paper-based thing where you have to go and hunt down your preceptor, being able to send the eval to your preceptor. So it can be a bit more organic, so that it doesn't have to, be, hey, everybody, let's take 10 minutes out from patient care to go fill out this very long, lengthy form. And then having things, for instance, for us, we have like a box that says, provide your written feedback. And personally, the written feedback is only a snippet of what that verbal feedback actually is. So it is a little bit more organic in the sense that I personally only care about that verbal feedback that's coming my way, because I'm using that and internalizing that, so that I can use that for the next encounter or the next patient situation. And then that snippet goes off to our assessment committee, and that's kind of what they use to say, oh, okay, like, they take all of the snippets together and they put that, and they use like a different lens to really say, okay, so the learner, started out here, did these things, the feedback started getting a lot better here, and then, oh wow, they've actually really progressed, and now they're competent in doing an airway by themselves, for instance. And there's the score that's associated with it as well. But I think from the learner's perspective, it can be organic if you kind of have the mindset that the encounter can be organic, and that the feedback you're getting from your preceptor is almost like a dialogue, as opposed to this checkbox that you're just completing.
That's
Yeah,
great.
and I think it's about how you incorporate it. So I think that I would say in services like Chad's and mine, where there's a lot of direct observation because we're co-located, that might be part of the administrative burden of trying to find your attending and then drag them to watch you, might actually be part of it. And I think that it's also a leveraging of getting used to the idea of, can you do indirect observations and things like that. And so as people get more comfortable with it, they start being a little more fluent with the EPA system. I do think that that's a big part of it. And Chad, do you want to tell people about the intervention that, not the Spencer that's having his birthday today, but the other Spencer that it's in our program, and Hussein Al-Rimwali and Beatrix Bersi, they created so that Spencer sample. If you could talk to us a little bit about that, that would be great.
Yeah, absolutely. I think both Hussein and Spencer, two of my colleagues, both of them are R3s in the Emerge program. They identified, at least when we were coming up, where can you identify these areas, or when can you identify it? Is this something that I can get an EPA, and is this a moment that I can take and go off and get one of these assessments filled out? And they actually created this case-based learning modules where you actually dissect through and you read a case, and you actually, as the learner, identify where are the learning opportunities, where are the EPA assessments, and how can you actually go and seek out that learning opportunity and that assessment opportunity with your faculty. And that's actually increased, I forget how much fold it's increased EPA acquisition by, twofold, just by being able to dissect, oh, okay, from this opportunity, I'm able to get 1 or 2 EPAs out of it. And that's given our new junior learners that opportunity in real life and real time to say, oh, wow, okay, I can actually get 1 EPA for this, an EPA for this, EPA for this. And not saying that you actually have to go out and get those right there in the moment. You can either just get informal feedback about, hey, today I stood at the foot of the bed during a resuscitation, and I initiated the first 5 minutes of that recess. Things got a little bit confusing for me in post-arrest care. This is where I want to work on. And you can at least fill out 2 EPAs for that. Communication, you can fill out the first 10 minutes for resuscitation, but maybe you didn't get to manage that airway that day. So there's various different ways that you can actually look at a situation and identify how can you actually get those assessments. And another one of my colleagues, Beatrix, another R3, she actually has a regular interval. She checks in with our junior learners, and most of them being off service in first year. She checks in with them in various intervals, and identifies and almost gives these little heads up as to, hey guys, these are some of the EPAs that you can get when you're on your obstetrics rotation or when you're on your anesthesia rotation. And it gives our learners a bit of a reminder and almost a bit of a confidence boost of like, oh, okay, yeah, I have to be, let me be seeking out these learning opportunities while I'm on this rotation. and areas where I can actually get feedback in, and also tips on how to approach your attending, because we've all gone through it now. We know the process, we know how to actually get it done, and that gives our junior learners a bit of a, like I said, a kick in the butt, but also a confidence boost to actually be a bit motivated to go out and get these assessments.
I would say
it's actually, it's increased
nudge,
by fourfold. Yeah.
She just nudges them. So if you've got a first year resident going off to spend a month with Daniel on internal medicine, we'll nudge them to say, here are 2 EPAs that you can focus on this month. If you focus on these, that'll be great. And I think that helps. Now, in terms of question, Naomi had asked in terms of how often you are assessed by the competency committee, and I told her in the chat there were 4 times that you're assessed each year. But can you speak to me about your experience of what that looks like? So on the back end, we have our competency committee meeting. There are residents at the table at those meetings. So sometimes I assume you'll get a report on some of the process issues, not on the confidential things. But then what happens after that?
Yeah, so I know, like, for instance, we will meet with Aleem and Kelly. So that's our PD and our assistant program director. And then we also have Dr. Chorley, who also kind of follows up in the back end of all of our EPAs. And they put it all together essentially in a very nice bundle of, this is how you're progressing in, say, for instance, your academic area. This is how you're progressing in your research area, in your EPA assessments. And this is how you're progressing in your simulation area and clinically. And they put it all together for us as learners, and we actually kind of see it on a dashboard, and we almost get all of that data given to us, and we can see from that data and from the data points, okay, where might I need a little bit more help? Where am I able to make improvements on? Do I need to change my study habits because my academic formative testing is not where I want it to be compared to my peers? Or, wow, like, I'm actually really crushing it in simulation. Maybe I can actually get an EPA for a more rare task or something that I haven't done before. How can I use simulation to my benefit? So all that information is given to us at regular intervals. And on the back end, as a learner, having those frequent meetings with our program directors allows us to use all of that information, because there's so much data that's generated from these EPAs. And having great faculty that are able to break that down for us in a very user-friendly way is very helpful.
Yeah, so I think you also get those reports from Dr. Chorley and the competence committee that just say, here's your progress, here, this is what you're doing well, this is what you could do, focus on next. So it's, again, more formative in that it's always like, what do we observe, and then what's the feedback going forward, right? So if you're rocking it, we'll tell you, you're rocking it, keep going, consider working on the next level, right? So most of our feedback, we're trying to train our faculty to generally think always, what did you see? And then what could the trainee do better? So we try to adopt that within the competence committee as well. That's based on a study that we did locally on some of our precursor program, the MCMAP program that we had before we came into EPAs. Okay, last question, and then we're going to do a breakout room activity because people have been listening to us talk for a while, and it was early in the morning. We were waiting for the caffeine to kick in, so it's totally fine. But can you speak to us a little bit? Ines Algahori has asked, are there certain tips on how to approach attendings?
Yeah, I mean, I'm where I would tell, like, I'm a pretty talkative guy, so I just will be very plain about it and say, this is what I want out of this rotation up front. These are the EPAs that I'm trying to achieve this block, specifically for me off service. Like, if I had Dr. Brand Vegas on internal medicine, it's very easy for me to walk up to him at the start of the block and say, this is what I'm going after this month. These are what I want to get out of the rotation, and then finding those opportunities to say, hey, after rounds, can you watch me, do the central line, or can you watch me, break bad news, or whatever it is that I'm trying to get out of it. Just asking, because at the end of the day, patient care, we all have the commitments of the ward or whatever service you're doing, but there is always 2 extra minutes that you can take out, and it doesn't take long to do these things. Like these assessments are not long-winded. Some of them can be, but for the most part, it doesn't take, an hour for your faculty to come and watch you, or even if it's through indirect processes, just being very forward about it and really motivating your learners to say, hey, you can actually ask your faculty for these assessments at various intervals. You just kind of have to ask. And by making it okay to just ask, it actually decreases those barriers that Dr. Brandvegas was talking about earlier. It makes it almost easy to do.
I was going to say the other part of it too is that to help enforce that on the back end. I'm pretty sure that if you told Aline that there was a teacher that decided not to or refused to, that he would probably have some, words with the various program director from that program and or the faculty themselves. So I think that's the other part of it too, is that, I think that having a proactive learner is one part of that, and there's a complexity behind it as well. Psychological safety is also part of it, right?
Yeah.
Chad's pretty brave, so his psychological safety's just follows his bravery high. But I mean, that comes from the fact that you've been off service on critical care rotations, and asking for EPA is not life and death, right? So when you've seen and brought people back from near the brink of death, I feel like asking for an EPA is a very different phenomenon, and hopefully some of that clinical bravery that you've learned can make that easier. But you can imagine back in PGY1, it probably was a lot harder. And in PGY2 got easier. And now in PGY3, you're, hitting your stride and you're used to it by now. But you may need to think about kind of like back in the day to stand behind the junior learners to make it so that the faculty know that there's repercussions if they don't, right? So go ahead, Daniel.
From our point of view, I think with the faculty who are here, I mean, I would offer anecdotally, I think, rather than waiting for our learners to become brave or hoping that they're already going to be brave, which is great, and hopefully that's the case. But I think, things that we can do anecdotally that I've seen in other people and in my own practice at work is, we're not going to actually pull out the EPA form and say, here, we're going to do an EPA. Because we don't know what EPAs the learner wants, or if they're comfortable, we can give the feedback, we can do the teaching. But I think we have to take, if not a timeout, then it has to be a constant component of every interaction we have in the clinical setting to say, hey, if you need an EPA, we can talk about that later. Or, hey, we just had this discussion. Let me know if you want an EPA about this. I think if we normalize it and if we bring it up, and I know that there's a lot of reasons why, there's almost like a conflict of interest. It means more work for us. It means sometimes an awkward interaction. It means having to get home maybe later that day and actually spend time submitting that form. So it's easy not to say it and to kind of welcome that the learner didn't say it. But I think at the end of the day, if we make a habit of just bringing it up, learners, then it becomes normalized and they do get more comfortable. And I think then you can have a contract. So I'll oftentimes say, great. If they say, oh yeah, I really need an EPA for this, I'd say, great. So why don't you fill out all the contextual information and maybe paraphrase the feedback I just gave you and then submit it to me, and I'll edit it and I'll submit it. And so it minimizes the work on our end, but it also presents the learner with an opportunity. So yeah.
So we're going to move on to the activity. I'm just going to have two things. Number one would be to add on that Chad's always been a big advocate of growth mindset, and I will, by the end of the session, have popped in the chat a podcast that you can share. Is an interview with him. I think you were in PGY1, weren't you?
I think it was PGY1, yeah.
So it's the kind of like thing that you can like share with your junior trainees or early career folks to say, okay, here's growth mindset thinking, because if you bring it into the clinical space, then like your EPA entrustment, all that other stuff, it falls away, because this is all about you growing and talking about that. So I think that he says it better there. And then the other thing would be just we're going to head into breakout rooms, and Spencer, as his birthday gift, I'm inviting him to be one of the leaders in one of the groups with the activity. I'm going to put the activity sheet And one of you will have to screen share, and the task is going to be to work on this task together with everyone in the group. And so the idea here, I'll put the Dropbox link in the Dropbox. And this is a worksheet that you're going to basically audit someone in the groups. There's like going to be 5 or 6 of you. So Chad, if you can run your group, Spencer, Daniel, and myself, we're the 4 leaders. We'll just screen share, and there'll be someone that gets to take a look and audit their program of assessment and talk us through what they do. And if not, then I would ask the team leads to kind of walk through what their program does. And then you'll take a look at the activity and just follow the steps to actually audit and see what's missing and where are there opportunities. Okay, so I'm gonna put us everyone into breakout rooms, and then we'll be back in about
Maybe
20 minutes. Yeah, sorry.
Before we break out, any questions? Does anybody need any clarification? Are people in general clear? We can clarify more details as we're doing the activity, but any general questions or is anybody completely lost into what we're going to do?
Okay, I'm going to put us into the rooms. Okay. All right. Okay. Well, welcome back to everyone. Thank you so much for doing that. I'm just going to ask everyone to take a quiet moment of reflection and maybe jot down one key point that activity kind of revealed that you'd like to take back to your program. So just take a moment to think about it and commit to some kind of change, because that's evidence-based, and Jonathan would have my head if I didn't actually start using some of the evidence. And as we're starting to think through that, I will introduce Dr. Jonathan Sherbino. He's Assistant Dean of Merit, so that's McMaster's Education, Innovation, Education Unit, basically. I'm really excited to have him here. First of all, congratulations on winning the National 3M Award. Woo! That was announced yesterday in Maclean's magazine. Not that magazines exactly exist anymore, but at least the website does. So, so excited about that. And so it's exciting to be in the presence of someone who's thought so deeply in education to kind of talk a little bit about programmatic assessment and where we might be a little bit more scholarly about it. So Jonathan, do you want to just kind of give a background about where you think education scholarship maybe fits in for the crew that we have here? We have a mix of trainees and program directors and program admins.
So sure. So thank you, Teresa. And I know many of you, I'm going to do a shameless plug. If you don't know about Merit and you are a part of this workshop, then that's something how your university needs to get fixed. So you can find us at merit.mcmaster.ca. We have a whole bunch of monthly events. Being a part of that community is really low stress for you. So I know that everybody here probably is doing 1,000 things. And we just operate on a pure motive of FOMO. We offer so much stuff that you feel like, man, I wish I could go to that. And you are internally guilty or are disappointed. So we just use that social psychology of wanting you to be a part of our conversation. So think about whether you want to join. And then thank you for the kind words about the 3M. You know, the comment I'd say that's relevant is that in putting together the dossier when McMaster put me forward as a nominee, made me go back and look at all the things I've done. And you never start with a master plan. You start with some very, very small projects. And one of those very, very small projects turned out to be not so very small. And so Teresa, maybe you can talk a little bit about the story about McMap at some point. But it was a project that said, when I came to McMaster, I looked at how we were doing assessment for our trainees and thought, this is terrible. Like we do way better than this. But a new faculty member doesn't get to say stuff like, this is terrible and you got to do better. And recruited Teresa, who at the time was a resident. You were a PGY too?
Well, I made I don't know if it was a mistake, but I was upstart enough that I was a junior rep on the RPC at the time. And my program director at the time was like, yeah, we should redo this daily assessment form. It sucks. And I was like, well, I can help. And our APD was like, yeah, as a resident, you should help, but someone needs to take the lead. And then of course there was like crickets. Flash forward a year and a half later, I'm doing my medical education fellowship year in PGY4, starting my master's, and Sherbino and Ian Prayer come back up to me and say, so that offer that you made a year and a half ago, we remember it. Are you game? And so that was the beginning of the end.
And so all of that to say is, you don't have to be so ambitious that you're going to develop. So Teresa, and with my collaboration and with many others, we built a program of assessment that at the time was a conceptual idea in the literature. And I think we built probably the world's first functioning, working programmatic assessment piece. And we've written a number of papers. And what you don't know about the backstory is that it was the template or the beta version for the programmatic assessment model used by Royal College of Specialty Programs. It was a proof of concept. And so I could regularly sit in meetings and say, this can work. Let me show you the data that we are building at McMaster, and this is how it's working, and here's where the hiccups are. And so that's all out in the public domain. There's a bunch of papers you can read about it, but we're not here to talk just about Big Map. The meta narrative I wanted to say is not every project you need to do has to go on and be so longitudinal and so big, but sometimes these little small ideas that you do start on because you're really passionate about can have an impact that just continues to grow and grow as you recruit more and more people into participating. So I can't even remember what your original question is, but I think it was something along the lines of, is programmatic assessment, or where is it in terms of the literature? Is that kind of the question you started me with?
That is the question that I gave you in the email. Yes. So
Okay.
where are we at with programmatic assessment, and what's the kind of the literature saying about it, and how might people join in the conversation?
So assessment has always been kind of a super prioritized, mostly from a grassroots point of view, a prioritized theme in the health professions education literature. And I think it's because, and so that doesn't mean it's better or more important than other things around selection or teaching or different theoretical models. It just seems that I think particularly as clinician educators, we gravitate to assessment because we want to understand what has been the impact of our learning, what is the responsibility we have to society. I mean, there's probably a whole research project into why assessment really predominates the literature. I suggest to you, just go to the table of contents of your favorite journal right now, and I'm going to tell you that at least a third of the papers will be about assessment this month. Programmatic assessment is where everything is right now. And so I have a podcast, and we recently covered two papers that I think are relevant to this story. And at some point, I'll try to find those references and send them to you. And Teresa, if you're doing that on the back end, the one paper would be about psychometrics, which is a bad example of programmatic assessment by Champlain. And then the other is the Van der Vleuten Schuwerth History of Assessment paper. So you can find those two podcasts. So if you want to hear a more intelligent version, basically from people who've actually written about it, there is a link for two versions. Programmatic assessment is how the current conceptualization of health professions education is looking at it. And when we say programmatic assessment, we say, do you have a blueprint that maps to the outcomes of your training, that captures multiple authentic pieces of data? So work-based assessment is a real driver, but that includes other types of assessments to make sure that you're capturing all of the facets of your training. So written exams are still cool and are still effective ways at looking at knowledge. But do you have a way to then aggregate all of that data into a cohesive narrative with the use of a competency committee, so a group of peers and content experts, to make summative decisions about the performance of a trainee as they track towards unsupervised practice? And to emphasize the keywords there is we need lots of data points so that we get multiple perspectives. We're no longer worrying about training one person to be the perfect, purely objective rater, because we don't believe in objectivity too much. But we want lots of perspectives that we are able to triangulate a sense of here's what's happening, that are authentic. So we don't want to say, wow, you can do great at OSCEs or simulation, but we have no idea what you actually do when you go to clinic or you go to the OR. And we want that collective wisdom of content experts to say, okay, here's where you are, so that educational prescriptions in a summative way can be given to your trainees. And that at the end of this arc or this trajectory, you have a really auditable, robust, rich, rigorous description to say, okay, this person has come from novice to competent or expert, And here is all the evidence. Here's the case we would make in the court of education to say this individual has really shined. The first podcast I recommended to you is archaic perspective, is how we think about assessment, which is to say, okay, we want to offer really high stakes assessments and focus on all the psychometrics of the pieces. So the example would be the LMCC Part 1 or the Royal College Specialty Exam. We're going to put all our eggs in the one basket and say, we're going to work on making this one test, whether it's 2 days or a half a day long. And we're going to say, this will be the only arbiter of how you're successful. And that's an archaic way. We don't think about that in health professions education as being the standard of training. Although there is still value in having those summative knowledge exams. But if that's all you have, then you have a very unbalanced, very fragile assessment to say this trainee is ready to perform surgery or do psychotherapy or lead a clinic in providing chronic care or providing care for chronic disease. That's insufficient. The second link that's there talks a little bit about where we've come and all the kind of the stages and the steps that we've moved through. And I won't waste all of our time doing a kind of a rewind on the history of assessment in health professions education, but that paper is great. If you want to kind of spend 30 minutes and say, okay, I'm going to get the best version of where we are and where we've come from, that paper walks you through it from some giants in the field of medical education. And it says, here we are at programmatic assessment with the trailer or the teaser for what is the sequel going to look like, because we're not going to end here. And I think that's really the point of conversation I think we have here. It's not like programmatic assessment is the one ring to rule them all. It's a better version of what we've had, but we will continue to evolve and advance it forward. And I think that's where the opportunities for assessment come in. So that's a diatribe. I'm going to get off my soapbox and maybe try to make my answer shorter, but that's kind of where, how did we get to here answer?
Yeah, so that's a fast forward into kind of like where we've gone from psychometrics into the era of looking at more varied types of assessment to put it all together. And so we've got a lot of people who are program directors, PAs. And so to me, I think there's an opportunity right now in terms of the implementation of all this stuff, because like you said, there's some literature out there, but most of it's actually pretty just theoretical. It's just like, here's an idea that I had and isn't necessarily about workable examples of how programmatic assessment works locally at the grassroots level. Is that correct?
Yeah, so this is a time for you who are building data to really test the assumptions. I'll give you a couple of great examples. So we have decided that entrustment is the way to go, right? So think about your EPAs. The killer feature of an EPA right now is that we go from a behaviorally anchored scale to an entrustment scale. And we think that aligns really well with what we've always done. Think about your own practice, think about your own training. It was how much autonomy and how much do I overtake and intervene with what I'm allowing my resident or medical student to do, whatever discipline you are. And that's kind of been the history of medicine. I'm in the room or I'm not in the room. I'm at home or, oh my gosh, I'm going back into clinic or back to the wards or whatever your practice looks like. So that's the assumption that we have, that entrustment scales are the killer feature. I have just finished work on a systematic review of the OSCAR, and then there's a separate paper, a scoping review on entrustment scales. And I will tell you, there is not a lot of good data. There is big gaps. And so even though we're using entrustments like they are superior, we don't really know if that's the case. And we're not sure how they actually perform in the real world. On paper, Ole Tankate, every time I talk to him, says, this is gonna be the greatest thing I've ever seen. And my answer is to Ole, okay, I buy the theoretical argument, but let's see what happens when we take that theoretical thing and give it a spin and drive it around in the actual messy world of health professions, in labs and clinics and ORs, in wards.
Yeah.
And so this is an opportunity for you to say, okay, here's the assumptions, let's look at it. And an example of that is Michelle Moret, who I don't see on the call. And so Michelle Moret, the program director for OB-GYN, has just done some studies looking at how they use EPAs in obstetrics. And so they have the first two cohort years, and they've done a mixed methods study, which is trying to say, okay, who completes the EPAs and what does the scores look like? And then they did some interviewing with faculty and residents and say, what do you think about these EPAs? And I'll tell you that she's presented this work, so I'm not stealing her thunder. So it's in the public domain, but it's out for publication. Guess what? EPAs don't work as well as we thought in a very limited sample in obstetrics. As an example, everybody has a score of about 5 on average, because residents are really worried to ask a supervisor to evaluate them for formative feedback. They say, this is not formative. You guys can say it's formative all you want, which really is secretly summative. We know that you guys are playing a bait and switch on us. And so then when we ask, what do you guys think about EPAs? The faculty say, well, it seems to me it's more work. I could have just done what we always did. And the residents say, we're nervous. It makes us scared. There is risk here. And so that's really important information to the OB community here at MAC, probably the OB community in Canada, because I can't think it's dramatically different here, Toronto to Western to UBC, for them to say, okay, do we need to rethink the faculty development or the implementation we have for EPAs? So that's just a vignette about testing the theory, because the gaps in the actual applied literature are pretty big.
Yeah, and so you can imagine walking that program of research out to saying, like Spencer Van Mill is suggesting, like, do you think that faculty triggering EPAs may be a way to fold that in? It could be. It could be that you give everyone Chad's growth mindset podcast and say, listen to this and see if you can actually change the number of EPAs that are 3s, 4s, and 2s, right? And so the idea would be there's different things that you could then test and vary and actually improve. And so just like any PDSA cycle, you may want to actually think about what it is that you want to change in the system that exists, but you do need to do some baseline measurements, right? So those of you who are QI minded, PDSA is something you probably know, but some of you might not have heard the term before: plan, do, study, act. It's a kind of cycling, kind of like rapid prototyping / improvement process that people use in the QI literature. So, and for those of you who are interested in that kind of work, I think there's a big merger between the quality improvement and implementation science of education and what we're doing in the clinical realm. I think there's a lot of crossover, because the reality is that Jonathan's group is, dominant by a lot of people who are doing great scientific work, but they're like the bench researchers of education. We have to go and take some of the work that the Merit group does theoretically and then test it in real world, because maybe in a lab and maybe in a very tight circumstance, it might work. So for instance, emergency medicine, we did the McMap stuff, then we evolved to EPAs. Our environment is going to be very different than McGill, let's say, where they didn't have 8 years of experience doing workplace-based assessment before they transitioned over. So it wasn't a software update, it was a hardware and software update, and everyone's scrambling in terms of how actually people operationalize those EPAs. And so you can imagine those opportunities are very different. And so understanding the psychology behind some of these implementation and how it works, I think that's the sweet spot where program directors and clinician educators really can inhabit the space.
I just want to amplify a couple of things you said, Teresa. So one, Spencer, your question is a research question. Like, go and try it out and see what happens, right? That's a publishable thing that a whole bunch of other program directors would be really interested in. I also want to give a shout out to Leslie Martin, who is from Department of Medicine, in her qualitative work about how EPAs are perceived and used. If you haven't read that as a program director, it's assigned reading. It's local data. And so you might not be an internist, but the faculty resident power dynamic is still true for you as an oncologist or as an emergency physician or as a neonatologist. I'm trying to scroll through here and see everyone's names. So if I'm missing your disciplines because I can't see everybody's names all at the same time, is relevant. The idea of translating the theoretical framework to the clinical practice is really important. So at Merit, we have PhD scientists, and one of the things we're looking at around assessment is the speed with which you can diagnose an X-ray or an EKG a nice surrogate for expertise, because it's pattern recognition. And so we know theoretically that experts have a better categorization, pattern recognition element. So if we just time you and measure you in milliseconds, the time for which you get to the right answer, is that a better marker of competence? Sounds really great in the lab. And so we have people looking at screens and we are showing them an X-ray at about 100 milliseconds and seeing whether they can figure that out. And you have a bit of retinal retention because your retinas can still have the image there. So it's probably a little bit longer than 100 milliseconds. We see signal. But if you're a program director, your first question is, what the heck do I do with that? And so there is a real need to translate the theoretical to the practical. So the type of questions you ask about, should it be the faculty member or the resident driving the EPA assessment? Is there ways that we can prompt or influence faculty and residents around growth mindset with Chad's podcast? These are all very legitimate types of questions of scholarship. You don't have to be using these kind of weird cognitive psychology stuff that we might be trying in the lab. We do stuff with eye tracking and strap cameras to people's heads and whatnot and see, is there some element of expertise? Really helpful, but not a recommendation that program directors start to buy eye tracking software in addition to all the iPads they have to buy for their residents as a mandatory educational aid.
Yeah, and Ines is highlighting that the beauty of QI is that you don't need a large sample size, because what you're trying to do is actually focus in very deeply and intimately at a smaller group of people and change the system locally, and then be explicit about the kind of change process you went through. And I think I 100% agree. I think that like you don't, not everything needs to be an RCT. You know, that's always been my kind of like perspective on some of these things. So in local data sets and local culture, you know, as Drucker said, culture eats strategy for breakfast, right? And so you may have the best strategy in the world, but local culture, if there's no psychological safety, if there's no growth mindset, if there's no attitude towards wanting to aspire to greatness early on in your training and trying to transition to practice EPAs and PGY1, then guess what? People are going to ask only when they're ready, and so they're going to only get fives because they're not feeling safe, right? So that's an example of dissecting out using the theory and then saying, okay, now let's test those assumptions. If that's the case, then if we can increase psychological safety in a program, there should be more 3s, 4s, and 2s in the system. Right?
So maybe to add just a second to that, yeah, I think a valuable perception is also to bring in, you know, other conceptual frameworks or other kind of perceptions beyond what we're talking about psychometrics, and we're talking about psychology, and we're talking about, you know, validity. But when you think about it, you know, if you use an economical perspective, what are we incentivizing with our EPAs? You know, learners will all the time say, why would I waste my time and why would I waste your time filling out anything that's not a 4 and a 5 if it doesn't get me anywhere? I only advance with 4 and 5s. And so I'm happy to get the feedback and the learning from the 1 to 3, but let's not waste our time. Let's just fill out the forms that actually count. And I think, you know, that's another opportunity to analyze and maybe study this kind of issue from an assessment perspective that goes beyond the traditional psychometric or cognitive psychology or validity kind of perspectives.
You're right on the money there, Dan. You have a framework or a lens, and I think we should be thoughtful about what are our assumptions and what are the limits of the lenses and the frameworks that we apply. And there's a lot of different ways that we can look at this. I do want to say one piece, that if I was sitting here at the very start of my career, which would be a sense of massive imposter syndrome and a feeling of, oh man, that seems far too big to the scope of what I want to do. And it's not that you're going to run some really sophisticated analysis or some big study that's going to get published in the top medical education journal. but that a lot of the work that you're doing here would really benefit your colleagues. And so this is a shameless plug. So we have something called the Norman Education Research Day. It's June 9th. I'm not sure, 100% sure of that, but it's an opportunity for you to present your work about the work here at McMaster. And so please sign up and come and hear about the different types of scholarship, and then jump into that assessment track and say, okay, what's happening? And then next year, bring your data and say, I want to present here. And there's a win-win in the sense of, you don't have to duplicate the knowledge and wisdom gathered by one of your colleagues who said, okay, listen, here's what we see in OB, or here's what we see in medicine. And it may or may not be relevant to you because your environment might be even more nuanced at the micro environment level. Or you might say, that really makes sense. That really kind of captures what our challenges are, because we are using MedSys and there's limitations to that software and it makes sense. And so it lets you share and learn so that everyone doesn't have to keep duplicating similar work, but it also gives you that first step into what it looks like to be publicly disseminating your scholarship. And presenting there goes on your academic CV, and it's the first step of building momentum. And then maybe you're presenting at one of your national specialty societies, and then maybe you're publishing your work in a journal that's relevant to your clinical discipline. And then, 3, 4, 5 years down the road, suddenly, wow, I've put together a paper or two and have started to collaborate. And these 3 programs here at McMaster are all doing a multidisciplinary study that builds on all of those early steps that have come before. So it's not like you jump into the deep end and say, okay, I'm ready for my multi-site mixed design 3-year-long grant-funded study. I think that is a bar far too high. There's a whole bunch of smaller, earlier steps that you can begin and have an impact locally and move even more broadly.
Agreed. And so I think that's a big plug to joining maybe Merit as a group. Daniel, Jonathan, and I are all associated with Merit, so there's a conflict of interest there, but it's free. There's a little bit of paperwork involved. That's the only thing, is a bit of a time sink and an ask of someone to sponsor you forward. But it's not that high a bar to climb, but definitely gives you access to things and allows you to kind of diversify the opportunities you have. And like Naomi has reflected, the idea is that sometimes you don't know what else is going on around, because especially right now during this very discombobulating time of Zoom-based meetings, there's not even you just end your Zoom and you don't get the chit chat about, oh, what are you up to these days, Adam or Eva, right? When you run into each other, because there's no running into people anymore. So definitely, I think that we need to go out of our way to understand, and perhaps that's something to kick over to Lisa and the team who do the CBME workshops, is maybe even just creating a space, right, for people to share would be very cool. I know Jonathan, you're involved with some of the scholarship committee and stuff like that at PGME, so maybe that's something that you could work with the team to figure out. But all right, well, that's about all the time we have. Jonathan, thank you very much. I will stick around for a couple of minutes just to be here to, if anyone has any questions or anything like that, I'm going to end the recording